Hi, everyone. Welcome to our webinar today. Thanks so much for joining us for the Research in Progress webinar series on preventing adverse childhood experiences and child maltreatment. I'm Sarah Brandspiegel. I'm an instructor at the Colorado School of Public Health, and I work with our program for injury prevention, education, and research, also known as PIPER. And in that role, I facilitate the National Peer Learning Team on Child Maltreatment, which is a national network of people in a variety of sectors who come together to learn more about primary prevention approaches to child maltreatment prevention and ACEs prevention as well. So our National Peer Learning Team is funded by the Centers for Disease Control and Prevention, and it's a partnership of PIPER and the Colorado Department of Public Health and Environment. And we're very excited today to be hosting the 5th in our series of Research in Progress webinars this year on preventing adverse childhood experiences and child maltreatment. And our focus today is research exploring pre-birth household challenges and early childhood ACE scores, implications for upstream prevention. So a little housekeeping before we get started. Please look for the Q&A button in your Zoom controls. And feel free to enter questions as we go, and we'll have time at the end for questions for our presenter, but I encourage you to put your questions there. The session is being recorded, and we will share a link with everyone who registered for the session when it's available in the coming weeks. And also you'll receive a feedback survey when you close out of Zoom, and please take a moment and share your feedback with us. That helps us with future planning for other webinars as well. I did want to draw your attention to some prior webinars we've had. These are all available on our website. So if you missed one and you want to check out the recording or the slides for these, please visit our site. You can see the different topics that we've covered here: gun violence, organizational policies to prevent child sexual abuse, community resilience, and opioids. And also take a moment and register for these upcoming webinars. We have one in November looking at promoting economic stability to reduce child maltreatment, so looking at the earned income tax credit. And December, community level interventions to address ACEs, learning more about some approaches in Colorado that are community based. And so we always like to start with a poll just to see who's joining us today. So please take a moment and let us know what sector do you primarily work in? Are you in medical care, public health, human services, nonprofits, business, education? And I'll give everyone a moment to vote. Okay, so most folks have voted. Let's share these results. So 44% of you all are coming from public health. And then it looks like nonprofits and community-based organizations are next with about 20%. So that's great. And I'm so glad. It's always nice to have people from a variety of different sectors joining us, since we're really interested in how everyone can work together on these topics that really cut across a lot of different fields. Well, now I'm going to introduce our presenter today. So Dr. Jared Parrish, he's the Senior MCH Epidemiologist at the Alaska Department of Health and Human Services. And his research focuses on quantifying the influence of systematic error on effect estimates, data integration, and incorporating novel methods for applied surveillance. And he developed the Alaska Longitudinal Child Abuse and Neglect Linkage Project, which is a mixed design strategy for estimating the cumulative incidence of maltreatment. And we're very pleased to have you here today, Dr. Parrish, to share some of your recent research with us. And so I will turn it over to you. And as a reminder to everyone listening, please enter your questions as they come to you, and we'll make time at the end for Q&A. Jared, you can pull up your slides.
Hopefully you're seeing them now.
Yeah, looks great.
Great. Well, thank you, Sarah, for the introduction. And I was telling Sarah before we got started on here how much I love these. And even though I haven't been able to join a lot of them, I love that they're recorded and I can go back and review them and see the collaborative work that's going on. Welcome to my office here in Anchorage, Alaska, and it's nice to have this wide audience from across the nation here joining me right here inside my little office, and I can feel you guys being a part of it. So I'm going to be talking about how we've, this transition of research that we've been doing to really be emphasizing how we can apply it into the work that we're doing. And so I put this title on here as Implications for Upstream Prevention. And then I have this picture of a glacier that I took. It's the Matanuska Glacier. And when I think about upstream prevention, if you go far enough upstream up to a lot of the headwaters in Alaska, you end up coming to this massive amount of ice called a glacier. And these things are huge. They're immovable. They're moving really slow. But when I think about upstream prevention, I'm thinking about shifting course and how much effort needs to go into it. And not that it's these really small things that need to happen, but some big things. And we're faced with these big ice chunks that we're trying to move. And so I thought it was just fitting to share how I'm perceiving upstream prevention and how it might need to cross multiple generations. So as we begin through this, let's see if I can get slides to move. All right, I can't begin without acknowledging the different collaborators on this work. Daniel Rittman, she's the lead author on a couple of the papers that we're working on, and she was a short-term employee that I had, and it was wonderful to have her up here. And now she's working with the Washington State Department of Health, working on some of their COVID-19 response. Also like to thank Paul Lanier at the UNC Chapel Hill School of Social Work for his work and insights, and Abigail Nubique, who also worked with us up here in Alaska for a while, but is now a PhD candidate down at Oregon Health Sciences University. And then just this last week, I recruited John Prindle to engage in some of the work that I'm going to be sharing today to help with some latent transition analysis, because he has a really nice knack for looking at that from the population level. So as far as what I'm going to be covering today, first of all, I'm just going to give a brief overview of what the Alcan Link project is, and I'm just going to touch real briefly on that. We have a website you can go to if you want to learn a little bit more about that I'll share at the end. And describe some of the initial work that prompted our current investigations that we're undergoing. And then I'm going to talk about the three studies that we worked on: the pre-birth household challenges with respect to its relationship with contact with child welfare, and then an ACE score of a child at age 3. And then we're exploring changes in household challenges from the pre-birth period to that early childhood period, and then that relationship with the contact with child welfare, to really kind of look at how the interplay across generations of what that household structure looks like. So Alcan Link, as Sarah mentioned, we refer to as a mixed design approach, because what we've done is that we've used data linkages to take an annual survey that is, and turn that into a longitudinal study. So built upon the backbone of the Pregnancy Risk Assessment Monitoring System Survey, or PRAM survey, that's conducted here in the state of Alaska, we link those respondents to a 3-year follow-up survey data that we have in the state of Alaska and multiple administrative data sets. The core data linkages that we do annually to follow our cohort prospectively is the Permanent Fund Dividend Database here in Alaska, which is effectively an annual census of our population. And it's those who apply for a proportion of the oil revenue that's generated from the oil industry up here. We link to vital records and our child death review data to see when we have fatalities in our state. We link annually to our Office of Children's Services, which is our state child protective services agency. And we link regularly now to our education records to look at school readiness, their developmental profile, and their reading scores. And right now, because half of our cohort we've assessed pre-COVID, and then we're going to be able to assess half of our cohort during COVID, we're looking at some registrant data, and we're also going to reassess reading scores later on to see how those are either failing, improving, or what. Alcan Link does use the 2009, 10, and 11 PRAMS cohort And the reason for that is a variety of reasons. One, they all shared the exact same face, so they all answered to the exact same questions. Our child welfare agency transitioned to a new case system in, I think it was like 2006. And by 2009, those data were really stabilized in there. And so it gives us a 3-year group of individuals that we can follow prospectively over time through a retrospective look. So for those who aren't aware, just going to real briefly touch on what PRAMS is. It's a systematic representative sample of live births in the state each year. Currently is conducted in 47 states. It randomly samples here in Alaska about 1 out of every 6 live births, and it's administered about 2 to 6 months after the birth. And like I said, it's weighted to represent the entire birth cohort, so we can make inferences to the birth population. It's a bimodal survey right now, but I think it's going to go to tri point in the future where they'll allow for online responses. One thing that is nice about PRAMS is that there are core questions that all of the states that implement it, they do ask on it. And so it allows for some comparability between states. And importantly, up here in Alaska, it is under IRB for both federal and local. And others who agree to participate in it do give consent for us to integrate data with other information that our department has on them. And so we are basically just expanding PRAMS into understanding the connections between the experiences that moms report during the pre-pregnancy, pregnancy, and shortly after birth window of their lives. Here in Alaska, we do have a follow-up survey. As I mentioned, it's called CUBS, referring to Childhood Understanding Behavior Survey. This survey is conducted once the child reaches the age of 3. There are a few additional exclusion criteria, like if they've moved out of state, they're not followed up on. Again, we do phone and mail follow-up on them. It's under local IRB. Alaska isn't the only state that does a follow-up. There are a total of 5 states that do have PRAMS follow-up surveys, but they aren't connected. Although they are trying to now, in recent times, be a little bit more aligned. Hopefully that would allow for some increased comparability. So the questions are unique to each state. But it is nice here in Alaska where we have this additional touch point for survey respondents, and about half of the moms who responded to the original PRAMS survey again respond to the CUBS survey. So I'm just going to give a little bit of the background work that started or was the impetus for the current work that I'm going to be talking about. So as Sarah mentioned, that the first part of this, the reason for this study was to understand the cumulative incidence of child maltreatment in the state of Alaska from the population perspective. And what we found on when we did this was that there's a lot of kids living in our state that are born in our state that are potentially experiencing some form of maltreatment, or something is potentially going on in the home that might not optimize health and development or well-being in their home. We found that before their 9th birthday, 1 out of every 3 kids experienced at least 1 report to Child Protective Services. About 1 out of every 4 experienced a report that was screened in for investigation. About 1 out of every 8 experienced a report that was then substantiated. And in Alaska, about 1 out of every 16 kids born in our state will experience a removal before their 9th birthday. And so from these data, we were a little taken back at how common this is. And there's been some national data that shows that these data are pretty much in alignment with what is seen nationally when we look at the cumulative incidence as opposed to the annual incidence. And we really started thinking about that first report, or having contact with child welfare, as a sentinel event that, from a public health perspective, gives us something to try to intervene or prevent on and focus on. And so we started building some research around understanding the context, the perinatal, the prenatal, and the early childhood factors that predicted contact with child welfare. And in a study that was conducted by Dr. Austin, who's at the University of North Carolina, she utilized these data and looked at a variety of preconception and prenatal predictors. And there's a series of questions on the PRAMS survey that we refer to them as the stressors questions, because it asks about, during the 12 months before your new baby was born, did you experience any of these 13 events? And that I have listed over here. And these 13 events are if during that 12-month window, did you experience a sick family member who had to go to the hospital? Did the mother experience a separation or divorce? Did she experience homelessness? Did her partner or husband lose a job? Did she lose a job but still wanted to work? Did she notice that she was arguing with her partner more than usual? Did the partner indicate that they didn't want the pregnancy? Did she report having a lot of bills that couldn't be paid, or that herself or her partner went to jail? Also, someone close had a problem with drinking or drugs, someone close died, if they experienced a move, and if she was in a physical fight. So there's 13 life stressors. And in this analysis, if children are born to a mother who experienced at least one of those life stressors during that 12-month window before childbirth, they were 76% more likely to be reported to Child Protective Services. And there were a variety of other associations, but after a meeting, it was in DC, and I was flying back, and I was looking at these stressors. I started noticing a relationship between those pre-birth household stressors and the household dysfunction that's categorized and grouped within the Adverse Childhood Experiences study, and thought about that from an intergenerational perspective. If those events that are occurring in the household 12 months before birth, they're probably going to continue on or have some effects during the early childhood window, which is time when we're trying to prevent ACEs or reduce the impact of them. And so this figure, taken from the Robert Wood Johnson Foundation, that just categorizes the ACEs scores, just conceptualize those events of abuse, neglect, and I like to think of those as events that the child they themselves experience, and then household dysfunction, which are events or environments where that child lives or is growing up. And so that really took us off into trying to explore this connection of looking at household challenges. And here we have household dysfunction, but CDC has really been making the move, and the literature is really making the move to refer to these as household challenges. And so you might see in this the term household dysfunction and me using the term household challenges, but I'm using those pretty much synonymously right now. And so sorry for the confusion if I do that. So this is how we mapped on the idea of linking this household challenges questions from the ACE, household challenges from ACEs, into the pre-birth household challenges as measured on PRAMs. And so we have a couple of questions here. And so when we looked at this mental illness question, now we don't ask the ACEs questions. And so the idea was, can we measure the constructs of what's occurring in the environment in that home with respect to these challenges? And so for the mental illness, there was a question on PRAMs that was related to during the 12 months before pregnancy, the mom reported visiting a healthcare worker to be checked or treated for depression or anxiety. With the mother being treated violently, we have a few questions related to the mom being in a physical fight. During the 12 months before her pregnancy, she was pushed, hit, slapped, kicked, or choked, or physically hurt by her husband or partner. For divorce, we have a question on separation and divorce. For incarceration, we have an incarceration question during that 12-month window. And then for substance use, we put a variety of questions that we have related to substance use. And so we chose to look at the stressors question, where they reported someone very close having a problem with drinking or drugs. And then we also included questions related to the mother's report of drinking, where she reported binge drinking during the 3 months before pregnancy, having any amount of alcohol the last 3 months of pregnancy, and then the use of marijuana during the 12 months before or during pregnancy. And so we combined all those variables, and we simply use those as a 0, 1, yes or no if you had these, and we use that as coming up with a pre-birth household challenges score. I'm gonna do this to move. And then to visualize what we're doing is that we're looking at the household challenges before the child's even born, as measured on the PRAM study. And then we're looking at abuse and neglect, which is the other component of the ACEs score. And now we don't have those measured on the Cub survey, and we don't have an actual self-report of that. What we decided to use was our administrative data from Child Protective Services. And so we used any report for physical abuse, emotional, sexual, physical, and emotional to try to map onto the abuse and neglect as measured on the the original ACEs. And again, not exactly synonymous for that, but still, again, just trying to measure the constructs, looking for these relationships. And what we found was that with the increased number of pre-birth household dysfunctions reported, there was an increase in the cumulative risk of having contact with child welfare this study was before their 7th birthday. And so it increased systematically. In fact, if a child was born to a mom reporting 3 or more household challenges during that pre-birth window, 80% of those kids experienced a contact with child welfare before their 7th birthday. And so if the mom reported two household challenges, it was about a little over 50% of those kids had a contact with child welfare. And you can see that stepwise association and the risk of contact with child welfare. That was the original work that we started on, and we're still trying to build out this work a little bit more to look at that relationship. But that gave us some motivation for further investigating these household challenges during that pre-birth window that really map onto the adverse childhood experiences household challenges. But when you get into the literature and you learn a little bit more about what are household challenges, there are so many things that can be included into a household challenge. And when you think about it from a cumulative risk score type perspective, they have to be correlated with one another, and they have to be filling in gaps or related to the stressors that can result in these negative outcomes. And there's a variety of research that shows expanding household challenges and things that could be included in there. And so we looked at some additional variables that we were interested to, and I just have these the blue highlights just indicate the original like ACEs stressors, and then some of the other variables that can be used to augment some of those. And maybe I missed some of them, but some of the things that we were really interested in including were really the issue of stress of economics, and including some of those components into it. And we looked at the relationships, the independent hazard ratios related to contact with child welfare. We saw these really strong associations with experiencing homelessness, being in a physical fight, maternal violence in jail, having threats by your partner, divorce, and then some lower effects of a sick family member removed, the death of a loved one. And so there's definitely some different strengths of the associations. And so we also wanted to explore some of those individual effects and expand how we were looking at this a little bit. And so what we did next, and what we've been working on, and this is a paper that's going to be published in Pediatrics here at the end of the month, and hopefully Sarah, when we send this out, we can send out a link to that. But what we've done is that we've looked at our household challenges in that pre-birth window, but we've included the financial component, the financial stressors into that component, or this household challenges, again, as measured on PRAMs. And then we've developed an ACE score at age 3 of our child. And we've used the CUBS data that also measures the household challenges, the same household challenges as measured in the PRAM survey, and plus the administrative data reported to our Child Protective Services Agency. And that's how we came up with an ACE score at age 3 for the children here in Alaska. And so the goal of this study was to look at the prediction of the number of household challenges reported during this pre-birth window and the average ACE score reported among children at age 3. What we found among our population in Alaska, among our 3-year-olds, was that over half of them experienced 0 ACEs at age 3, and 21% experienced 1, a little around 10%, 2, and then it was about 15% experienced 3 or more. And because we were using administrative data to fill in the blanks for abuse and neglect, we looked at it if we use substantiations by our Child Protective Services Agency, or if we simply use first report. And we really didn't see a whole big distinction between whether we use substantiations or reports. And so to be consistent with our public health model being inclusive and sensitive, we chose to further this research on simply using our first report as the abuse and neglect scoring to our ACE score. And the results of this was What we would expect. My wife is the great barometer for me, and she always says, Jared, you really needed a study to tell you this. And I'm like, well, unfortunately, I do. Um, what we found is that children born relative to children born with mothers reporting zero household challenges during that pre-birth window, if a child was born to mothers who reported one, two, three, or four more, we saw a stepwise association in the increase of an average ACE score of that child. And so we did do an adjusted analysis on this where we adjusted for maternal race, education, and age, and it really didn't change the stepwise association with any sort of significance between those. And so these household challenges that exist in that pre-birth window, they continue to have an effect into that early childhood window, which makes complete sense when you think about it. If you're experiencing homelessness and financial distress during that pre-birth window, it's not going to just magically go away likely once you add a child into it. It's just a stressor in and of itself. And so those things are likely going to transition with and continue on. And so when we think about preventing an ACE or preventing it, sometimes these kids might be born, and often might be born, with an immediate ACE elevation right at birth because of what's been going on in the household. And so that has some implications for how we approach this upstream prevention idea. Now, we've also looked at the independent associations of these individual household stressors. And so this table is actually labeled a little bit wrong. These aren't just the household challenges component. This is the household challenges model, the final model. And these were the variables that we saw independently after adjusting for the other household challenges, plus some of the other covariates that we were interested in. These were the strengths of the independent effects. So like experiencing jail, incarceration, the mom having a mental health issue, this idea of can't paying bills, all retained an independent strength. One thing that was interesting is that as Danielle was working on this project, she came to me lamenting that intimate partner violence fell out of her model, and I but divorce stayed in. And I said, well, look at the interaction effects of that. And lo and behold, she found this really strong interaction where when you look at among those who reported intimate partner violence, if they also reported divorce that occurred during that pre-birth window, there was no association with an elevated ACE score. However, if a mom reported intimate partner violence and didn't report divorce, there's a strong and independent association with an elevated ACE score of that child. And so when we think about this household context that's occurring and what's happening, and if that transitions into that childhood, it's going to transition into the child's well-being and development. And so therefore, we don't need to just say, well, intimate partner violence isn't important. It's that we need to look at it within the context with which it's occurring, and whether it's continuing to be a strong negative effect into the household there. So before I move on to this next study that we're into, one thing that's happened from this original research is that in collaboration with our Division of Behavioral Health, the Division of Behavioral Health applied for and was granted an 1115 Medicaid waiver to allow clinical providers to bill for intervening on these household dysfunctions or household challenges that are related to ACEs. And so we're working at, so they've identified the ICD codes that can be billable, and it enables our clinical providers to spend some time on these events and treat the system or the family, not necessarily just the child, with respect to these adverse events. And that really rose out of this initial work, showing that how this stuff just kind of moves through with respect to children and their environments. And so we're pretty excited about that and seeing what the effects of that will be over time. So now here, the final thing that I wanted to touch on was now within this narrative of looking at household challenges that are occurring in the home, we really now want to look at household challenges during the pre-birth window and how they change during that early childhood window and that's effect on contact with child welfare later in life. And so this one really focuses on the change in the number that the mom reports from the PRAM survey to the CUG survey and the overall relationship. And so when we look at the relationship of the blue line here, this is the stressors accumulated during the pre-birth window, and I think it looks orange to me, or salmon colored, the relationship of the number of stressors during the childhood. And so on the y-axis here, we have the number of stressors, and this is relative to moms that report 0 stressors, and the relationship with contact with child welfare. And so we can see that as the mom reports more stressors, whether we're looking at the preterm birth or the childhood, there's this similar stepwise association. But we do see stronger effects of the increase with the number of childhood household stressors, which makes a lot of sense because we're talking about more proximal events, and these are events that are likely often more reportable. And so if that events occur, it's like domestic violence. I know here in the state of Alaska, that would be, if the child's living in that home, that would be a reportable event under the mental injury classification. And so that makes a lot of sense here. And then what also kind of stood out when we first initially looked at it, that relative to the 0 stressor group, the 1 stressor, we didn't find any strong statistical difference based on how we were classifying and grouping our household challenges. And so our low risk group appears to be this 0 to 1 stressors. When we think about some of those independent effects of stressors, like moving and experiencing a death of someone in your home. And so this led us to believe that maybe we should be looking at 2 different types of groups of people: a low risk group during that pre-birth household period, and a higher risk group. And we broke out the low risk group and the high risk group. Among the low risk group, we see the distribution of the individual stressors that we're looking at. And we see a lot more of these lower effect, independent effect stressors occurring, like experiencing a move, experiencing the death of a loved one. Here we see some bills and some reporting of drugs and depression, but very little jail, divorce, IPV, and homelessness. Whereas in our high risk group, we see, again, a lot of move and death, but we see these other high events starting to occur more frequently among this group. So this led us to believe that there is a distinction that we can look at from the pre-birth window to the early childhood window. And what we found when we looked at these 2 specific groups is that among our low risk group, this is among children born to a mom who reported less than or equal to 1 household challenges during that pre-birth window. And so we made our reference group looking at the pre-birth and the early childhood group is no change. So they reported 1 during that period, and they reported 1 in that period. That's our reference group. And then we compared them to if that number decreased or that number increased. And when we, obviously, I mean, if you're in that 0 to 1 group, it's hard to decrease below that. So we saw no effect with the relationship with contact to child welfare. However, if we saw an increase, so you had a low risk group, and then you moved into a higher risk group or an increase your number of count, the probability or the risk of contact with child welfare substantially increased. So your risk increases. If you're in the high risk group during the pre-birth window, and again, our reference is you stay in that high risk group and your number stays consistent. If that number decreases, your risk of contact with child welfare significantly decreased. If your number increases, there was no effect or no difference in the change in your risk to child protective services. What's been enlightening about this and informative about this is that it's giving us some evidence now to take to our legislative group and those that have a hard time conceptualizing why investing upstream, investing in prevention matters. And now we have a little bit of evidence here that's starting to shed light on if we can address that household and help strengthen it and make that a really strong independent structure before a kid's even born or and during that kid's development, then we can reduce the likelihood or the potential for the likelihood that that child will be reported to child welfare. And that is a sentinel event for needing a lot more services in that family and that household. And so we're really trying to explore this area a little bit more and then develop it. And that's where we're going more. The challenge, and this is the glacier part of this though, is that these stressors cluster together. And so if a mom reports homelessness, this little graphic here is that the dark blue is the average number of additional stressors reported by the mom. And this is the pre-birth, and this is reported during childhood. So if a mom reported homelessness during that pre-birth window, on average, they have a little over 4 additional other stressors. During childhood, they have almost 5 additional stressors. Jail, you can see the additional stressors that occur Whereas if it's moving, you can see that there's a lot fewer additional stressors that are reported here. So when we talk about removing one stressor, you're actually talking about removing multiple stressors generally, and addressing that household from a holistic perspective. Just do a time check here. Doing pretty good. And so that's a challenge, that when we think about it, that intervening and addressing adverse childhood experiences, and CDC has a great document on preventing adverse childhood experiences, and compartmentalizes each one of these areas. But something that we really need to think about is that when we're dealing with homelessness, we're dealing with socioeconomics, we're dealing with incarceration, we're dealing with often substance use, and so we're dealing with a myriad of issues that are occurring in that home. And so identifying, isolating, and strategizing what each individual family needs to be most effective is where the rubber meets the road, and where we're really trying to chip away at that glacier. And so where we're going here is that when I was first taught public health, and I was taught prevention, I was taught as primary, secondary, and tertiary, and those make total sense to me. But one thing that I've really started learning when I take an intergenerational perspective on this is that the intervention for an individual, like a parent or caregiver, ends up being primary prevention for that child, and preventing it from ever occurring. And so I've started to shift my idea of thinking about primary prevention more along this continuum, with this intergenerational perspective, as opposed to just like one type of population that I'm intervening on. So we have this goal now, or this goal that I'm trying to help push in our state, is to really focus on supporting pregnant women and parents to build environments that maximize learning and development. And that was one of the reasons why we started really linking in our education records, because when children present at school and they're not ready to learn, and then they're likely to not be successful. And we start perpetuating this issue of children not succeeding in school and education. That's a really strong relationship with future success in adulthood. And the families that often present with children that aren't ready to learn at a higher proportion are the same families that we see here in these studies. And so health and education can really make a case to policymakers that they need to unite and braid their focus and share their information to help families be as successful as possible. So currently, right now, I'm in the process of building a tool. I've already started beta testing the idea of it, to assist providers with screening for these household challenges, ranking them with respect to their independent effects, and then moving on to diagnostics and intervention. Oftentimes, I've seen with respect to screening for ACEs, that screening process is also used as a diagnostic, where in a normal kind of medical screening perspective, you would screen it, and then you would then further investigate and perform diagnostic testing on it. And so the tool that I'm developing predicts a probability of the development of an ACE score of a child by age 3, ranks the individual components of those models, and then recommends further diagnostics on those individual components for the clinical provider to then determine, through the use of additional tools, whether those individual events are clustering together, having continued effects on that household and that family, and what intervention should be recommended to that family to give them some direction. And this is how we're trying to assist clinical providers, or my goal is to assist clinical providers now that we have that 1115 waiver for billable procedures that can take place. And so that's where we're going. When I think about this process of moving, addressing the glacier, it's always fitting that I'm here in Alaska with the Iditarod Trail, where some people did some amazing things to help out some individuals that were in need. And I always think of the researchers working in this area as us trying to do some amazing things, fight the elements, and chip away at a glacier to help families succeed. So with that, I think we have ample time for thoughts, questions, and any ideas. And if there's some thoughts that you have about it, please let me know. I'm always interested in learning from others and how we can make this research a little bit better. Thanks so much.
Thank you, Jared. Great presentation. And really exciting to see what you've been able to do with the data that you have there. And also, I think the power of using that data to be able to really influence policy. That waiver for billing sounds like a really positive step, and will likely lead to more interesting findings down the road. I'd love to get us started as people are putting their questions in the Q&A, and just ask, as you think about household challenges and that sort of whole construct of ACEs, are there things in Alaska that are unique to your setting that you think should be kind of factored in as people think about this, whether it's how people are experiencing challenges or the capacity to respond to those challenges as a system?
And that is a great question. One of the first study, which is now the second study, it always seems to work out that way. Your first study, you think you're going to do it and it's going to be done, but it ends up having more that you're looking at. What we have definitely found is that there is a difference between our indigenous and our non-indigenous populations with respect to the accumulation and the effect of those challenges. And now we don't know if it's how the surveys presented to the population and whether they're just interpreting or reporting those differently. But we do see some distinction. And we also clearly know from our state that how we intervene or address those things are going to be vastly different in some of our rural areas versus in our urban centers. But one thing that we've noticed is that the accumulation of stressors, regardless those, seems to have the same effect. What's included in those stressors, we might need to modify and think about it, but it shows that families in distress that in that pre-birth window are likely going to remain in distress, and what that ends up being is an environment that doesn't optimize health and development over the life course of that child, or the developmental window of that child. And so you're totally spot on with where we're going in this research, is to dive into those distinctions a little bit more to help inform. But yeah, that's been my simple observation.
Great, thanks. We have a question and comment here from Adam to share. He says, thank you so much for this presentation. We are running a legal clinic for pregnant mothers and new mothers facing CPS removal of their baby. Our clinic works to prevent the unnecessary trauma of removing baby from mom after birth, and works to safely get mothers into treatment and working with support. Do you see any ways in your work in Alaska that the medical world and legal world can collaborate to help provide that better intergenerational care for families?
You're doing amazing work there. It's an interesting world to try to live in, to balance the trauma and try to evaluate. I don't know, that would be great to see some studies to see leaving a child in the home where these events occur and removing the child and being able to identify which family and child that's going to benefit. I mean, that's challenging, and just thinking about that. Here in Alaska, I'm potentially, but I'm not in the child welfare side of things, and so I'm in the public health side of things. And I do know that we have the additional wrinkle of having a really large indigenous population, and so we are really cognizant of removals. And if there is a removal, making sure that it is as least traumatic as possible. That is fraught with a ton of challenges. And I can't respond to this from whether I see yes or no, but I totally see that if it's something that you guys are trying to expand, I'd be happy to connect you with our child welfare agency there to see if there's some sort of connection that could be done there.
Thank you. And thank you, Adam, for that question. We have a few questions about your data. So folks want to know a little bit more about your methods. Rebecca wants to know, how were you able to link the children to the school data? Was it a student number assigned at birth?
So I told myself that once I was able to link education data in this, I could move on to a different job, because I thought it was the mountain that would never move. But usually when I'm told no, I'm kind of get a little bit ornery. And so I try to figure out a solution. And really what it was is that I went down and I met with our Commissioner of Education. And that's one thing that's wonderful about Alaska, is that we're large geographically, but we're small population wise. So I can get a meeting with decision makers. And as we as I met with the Commissioner of Education and a couple of other advocates, the similarities and the connection between the families that are not ready to learn in school and what we're looking at were just so similar that the commissioner recognized that under FERPA law, that if we collaborated here, we could help improve school, the education and ability of kids ready to learn. And so we were able to create a data sharing agreement that our legal team approved. And then I linked it. So the way that we're a federated system, and so because it's only a sample of mothers, the education system sent me the names and a few identifiers to my data. I linked those data and then simply sent back their ID with those who linked so that I could then get the education records from those IDs. And then so that the names and the IDs and all that information always stays separate. But we were able to create this really nice relationship and a process in place to where we are doing this to improve the educational attainment of those children, because that's going to have an effect for our health as well. And so yeah, it took a lot of conversations and understanding, and I'm super excited that we've got it.
That's great. That is a mountain to climb for sure. That data sharing can really be a challenge. I wondered, you mentioned the permanent fund dividend and that unique data source. I don't think another state has something quite like that, right? So I wonder, like, how important was that in this analysis, and would another state be able to replicate what you did without having that permanent fund dividend?
So the permanent fund dividend just really, what it really helps with is that because I'm linking to administrative data and my denominator is the kids that were born in our state, as I'm following these kids over time, if they move out of state, I'm no longer able to detect them in those administrative databases. And so without that, without those data, I could end up having my denominator be a little bit inflated, because when they move out of state, they're no longer able to be detected. And I don't know if they are a case or a not case. I just treat them as not cases then at that point, or whatever the last status was. And so it just allows me to interval censor these population for out-of-state immigration. And that helps refine some of my cumulative incidence estimates. But it also, we found it to be really important when I'm comparing certain populations. Certain populations in our state are much more likely to leave the state. Like we have a large military population, and after 3 years, they're often gone. And so if I compare my military population to another population, then I'm at risk of making an inference that's potentially biased due to systematic error. So other states can absolutely do this when you're doing these analyses, because the effect of the out-of-state immigration kind of it drops. And so depending on how far you're following this population would determine how much of an effect. But if you know your population, what your general out-of-state immigration, then you would just be cautious at what comparisons you're making. We're currently replicating these methods in Oregon right now, and we've already shown that the cumulative incidence estimates that they estimate there relative to their populations are similar. And so the methods seem to translate beyond just Alaska. And we are going to explore different methods on how, if we wanted to really get nitpicky from an academic perspective on how much of an effect these not being able to account for out-of-state immigration, we might try some inverse probability weighting using the Alaska data on that with respect to some of the demographics there in Oregon. But we're also exploring other things. Other states have things like income taxes, that state income tax that you might be able to use. And so we don't have that in the state of Alaska yet. I mean, we might get that, but so there might be some other avenues to be indicators of whether that child's still there. Some education records might be an indicator. So there might be some other ways to knit together this replication of a longitudinal study.
Great, thank you. Staying on the subject of the permanent fund dividend, Des Runyon wants to know, is there any child abuse prevention benefit from that cash dividend? Do new babies get paid the benefit?
Yeah, so any child that's born on January 1 of the dividend year is eligible for it. And so they do have to have an eligible sponsor. So anyone who's under age 18 has to have a sponsor that would be a parent, a caregiver, child protector, a state custody. And there are some exclusion criteria with respect to, like, I think if you've been convicted of a felony. But when I looked through the data, If a parent has one of those prohibitive exclusion criteria, usually we see like a grandparent or the other spouse or some other person being the sponsor for that child. And so we do have some researchers right now. I'm partnering with a researcher at Georgia Tech and our Institute for Circumpolar Health that is looking at these data from an economics perspective with the idea of this unconditional cash transfer and its effect on child abuse and neglect or child well-being. And so because the timing of when the dispersal is known, which usually occurs in late October, we can look at children that have experienced one more versus one less based on their date of birth. And so they're exploring those relationships, and that work is progressing. Their first analysis on it, they had some pretty limited power because of what they were trying to do. And so we expanded some linkages through additional parameters to hopefully increase their power. But yeah, I'm excited to see where that research goes.
That's great. You'll have to keep us posted on that and maybe another webinar when that is ready to go.
I'd invite them to do it because sometimes that economic talk, they get to causation way quicker than I do. And so it'd be fun.
Yeah, great. Okay, we got lots of questions coming in, so I'm going to just keep throwing them at you here, Jared. The next one from Kelly, she wants to know more about the Medicaid waiver. And is that for medical providers, behavioral providers, or both?
It's both, and it's more inclusive than that. It also includes additional providers that might be doing some more indigenous traditional ways of healing and responding to that, and include but I think your two groups that you've identified there would be the two primary users that we would anticipate billing for those procedures. I'm happy to get some information around that Medicaid waiver and send it out to you to see. And Sarah, I can share that with you, and you can share that broadly. I provided some data that kind of got this process moving along, and then talked a lot about what those billable codes. I think there's Z codes that they were using too. We talked about what those might be. But yeah, it was designed to be really inclusive. To those that could bill and work at addressing those issues. But again, it's 1115, so the catch on that is that they have to show cost savings. And so they have a whole really big evaluation plan that's trying to demonstrate cost savings for being able to make these billings or beyond. So happy to share the additional information about that.
Wonderful. Okay, another question here. Based on your work that you're doing, do you have any advice for other state public health agencies that are trying to do more on prevention of child abuse from a public health perspective, instead of relying on social welfare agencies that are already overburdened dealing with families who are in the system?
You know, this is a challenge right now. I mean, I think one of the things that I've noticed is that public health in general recognizes an issue, but sometimes feels a little stymied to where to begin on this. And I really think that where CDC is going with addressing shared risk and protective factors, and some of the work that is coming out of the Injury Prevention Research Center at University of North Carolina with their using system thinking tools, is a really good perspective for public health to be looking at in this upstream issue of injury and violence prevention. Because these risk and protective factors are shared across entities, being able to address those and collaborate, I think is important. And, you know, when I think about what I've been trying to do here in Alaska from our public health perspective, is that I'm in Women's, Children's, and Family Health section, and I'm connected to our behavioral health section. I'm connected to our child welfare agency, and I'm connected to our judiciary system. It's being a partner in those discussions and really helping those other entities also see the benefit of public health being involved in those conversations. I have noticed early on when I was here in Alaska that when I was like, hey, public health is here to help, that the child welfare agency at first was like, okay, great, but this is our problem. We'll take ownership of this. And then as they have seen how we're trying to help not take over or change what they're doing, we've had a lot more collaborative work together. I totally blanked on where I was going with one of these other prevention thoughts, but that's really what I was thinking more of. The shared risk and protective factor framework builds a nice foundation for us to work from a systems perspective on this. And then, oh, I know what I was going to say. And then also trying to embed and infuse what trauma does to an individual across different public health topics. I remember recently, it was about a couple of years ago now, I was working with our environmental group, and we were responding to a community that needed an environmental scan because of um, a military operation that occurred there, and they felt that contaminants were impacting their health broadly. And when we did all the investigation on everything, the only thing that was found that was increased in that community was smoking rates and lung cancer. And the environmental group said, see, it's not the contaminant. And sat around and like, see, it is the contaminant, because the community is this stressor that hasn't been addressed appropriately, and they're coping with it with the smoking. So until we address the contaminant and validate their concern, we're going to continue to see this effect. And so this idea of trauma, whether at the individual, community, or family level, really hasn't transitioned into some of these other aspects of public health for them to be thinking about it. So I've been trying to diffuse that a little bit more broadly too.
Great, thank you. A related question from Natalie. She asks, based on this research, if you could give a county that's trying to prevent child abuse and neglect advice on how to make the biggest impact, what would you recommend? And do you have any resources that help make that case?
So what the two areas, so when I think about intergenerational prevention of child abuse and neglect, from a public health perspective, I would be really trying to work really closely with our teen dating and violence prevention group, and teaching about healthy relationships and building resiliency, building self-regulation capabilities, and teaching them what healthy relationships do and do not look like, and start establishing that pattern right there early on. And then I would transition into all hands on deck during that pregnancy period. That's an opportunity time where we have much more contact with the family. We have much more discovery of what's going on in that household. We can understand a lot more that's going on. And when I identify families that have multiple stressors or something that's really impacting them at that time, it'd be all hands on deck to address that before that kid comes in. I don't have kids. We were never successful in that area, but my family, friends that have kids, they always tell me that when they have a kid come into their home, it's a stressful thing. They cry a lot, they keep them up a lot, and so whatever I could do as a county, focusing on helping that environment be as successful as possible to welcome that new child in, is where I would be going. Because when we think about it from the perspective of trying to reduce government involvement and work into a family's life, if we can support that small business, which is the term I use in Alaska because we're very fiscally conservative, that if we can support that small business early on and feed them the resources they need and break down their barriers early on, then they likely won't need government services later on in life to help support them to catch them and when they deal with a variety of different stressors. So that's where I would be putting my efforts. Hopefully that broad question answered enough.
Yeah, I think it's a great answer, and so appreciate you taking the time. I'm sorry we didn't get to all the questions, but you have Jared's contact information, so if you'd like to reach out to him with your questions, I think he's open to that. And we will follow up with some of the resources and links and more information mentioned in this talk in an email, along with the information on the slides. So I just want to thank you again, Jared Parrish, for being here today and presenting your work. And thanks to everyone who joined us. And please join us for some of our future webinars as well. Have a great day.
Thank you.